Hello, I'm Dr. Patrick Hwu, CEO of Moffitt Cancer Center. We're here in Houston, Texas at the 2024 SITC annual meeting, and I'm here with Dr. John Mullinax, a sarcoma surgeon as well as an immunologist. So thanks so much, Dr. Mullinax, for taking the time to be with us today.
Thanks for having me. It's been a great meeting. I think there's so many great concepts that are being presented here, especially in the field of sarcoma. There's so many opportunities now with the new TCR-approved therapy, afami-cel, and several talks and presentations and posters about that. So really excited to see sarcoma represented here at SITC and all of the efforts that people are presenting here.
Wonderful. And you're running a really interesting trial, a TIL trial for sarcoma. Tell us about that.
Yeah, so TIL, or tumor-infiltrating lymphocytes, were recently approved for metastatic melanoma, and so we think that there's an opportunity there for patients with sarcoma. Unfortunately, for patients with sarcoma, there's not a lot of great treatment options once they fail standard of care therapy, and so we're working really hard to bring TIL therapy to sarcoma patients. We know it's going to take something different and something novel, and so the first step is really to establish the feasibility of that and then move into a trial where we have an infusion product that can deliver a response.
Well, there's hundreds of kinds of sarcoma.
Right.
So do you think TIL and T-cell therapy will work better for some sarcomas than others?
I do, and I think unfortunately, many times they're named based on how they look under a microscope, but we know actually it's probably the molecular underpinnings of these sarcomas that's probably makes them more or less sensitive to immunotherapy. And so rather than thinking about them in terms of names, we're starting to think of them more in terms of what caused those sarcomas. And that's some of the things that are being presented here at SITC this week and helping us to understand that.
I see. So give me an example of how they're now being categorized, thinking about the immune system and the microenvironment.
Sure. So, we conventionally think about TIL therapy being associated with what we call tumor mutational burden, or how many mutations those tumors have. We know that in general, sarcomas have very few, but there are some subtypes that have higher mutational load. Things like undifferentiated pleomorphic sarcoma or dedifferentiated liposarcoma. Others have expression of things that we call cancer testis antigens, which is the example I mentioned earlier with afami-cel, where it's a shared mutation across multiple different tumor types. So that's a great example where rather than putting in a category of a name, we're thinking about the expression. And so these antigens that are being discovered that are shared across tumor types really make that treatment like that possible.
That's really exciting that you're almost recategorizing and lumping the different sarcomas in the different categories.
Yeah.
And that will help guide the different immunotherapy and other treatments for the sarcomas.
Yeah,
it's great. It really helps because it's such a rare cancer and it's got so many different kinds. It's really great to categorize it in terms of the immunogenicity.
Yeah, if we drill down too much on a subtype, we're really restricting those options for patients that would otherwise benefit, right? So MAGE-A4, for example, just approved for synovial sarcoma, but there's other tumor types that have MAGE as well. And so why not try that for those?
That's right. Well, very exciting. So it's very exciting that immunotherapy is really reaching into these sarcomas, these rare malignancies. So thanks so much for being here with us today.
Thanks for having me. It's been a great meeting and I appreciate the opportunity.